All. One second. Before he starts, I just would like to say a few words. This topic titled Obstetric Hemorrhages. Actually, this sort of cases cannot be kept in the exam. A bleeding patient cannot be brought to the exam in virtual, I mean, a live program if it is going to happen in future, okay, like yesteryears. Definitely, you cannot have a heavily bleeding patient coming and being kept as a case in the examination. So, from that point of view, you need not worry. But this topic is repeatedly asked in the theory papers. How to manage massive obstetric hemorrhage, or what are the causes of postpartum hemorrhage, and how to manage or bleeding episodes in pregnant women. Like that, the wordings can be different, but more or less the answers will be the same for everything, because it's mainly concerns about hemorrhagic shock. That is the basic pathology that is happening in all these cases. And in addition to that, there are a few nuances in this which are a little different from trauma or other cases where the massive hemorrhage or bleeding occurs. So, from that theory point of view, you have to know this topic in and out so that you can answer. And an intelligent examiner may drag you from this to so many other sub branches of this concerned specialty. So there are a lot of questions which can be asked, which you may not be suddenly aware in the exam, taken by surprise. So I would like to know how you have prepared for this particular question here. And once you finish, we will summarize how to go about discussing this topic, if it is coming in the theory, or if they give you as a scenario and ask you how you will manage, then also you have to know. And once in a rare while, in your future practice, if you are going to take up obstetric anesthesia as your main career, suddenly by surprise, one case which all went on normally, a primee coming for emergency cesarean because of fetal distress or some maternal problem. Everything going on well, baby delivered, but the uterus is not contracting and the bleeding is going on. And yeah, especially if it happens late in the night when you have no help, you may be suddenly taken by surprise. So, unless you have a basic sound knowledge, which cases can suddenly turn into this sort of difficult problems, you will not be able to manage that. So, from that angle also, unfortunately, if you happen to get into a problem like that in an odd hour when you practice, then this basic foundation and knowledge will definitely help you to manage the situation and safeguard the life of the mother. Okay. So from these angles, you have to present this case. So you can go ahead now. Yeah.
Good evening, sir. My case, Mrs. Subhashree, 22-year-old female, residing at Perambur, Chennai, who is a housemaker by occupation, presented to the emergency room with complaints of bleeding per vaginum since 2 hours, and she is pregnant for the past 9 months. History of presenting illness. She was apparently well 2 hours ago, following which she felt a sudden gush of fluid rushing from her vagina area, and she presented to the emergency room with complaints of bleeding per vagina, with no recent history of trauma, no history of any abdominal contractions, no history of passing blood clots, no history of fever, no history of leaking PV, and fetal movements are perceived well. She had a last meal at 4 hours back. Solid foods have been taken. Antenatal history. In the first trimester, she had a spontaneous conception, which was confirmed by urine pregnancy test, and she had a regular antenatal visits. She's a booked case. She had no history of nausea, vomiting, or fever, or rashes, and no history of exposure to radiation. No history of spotting PV or pain abdomen in the first trimester. Coming to second trimester history, quickening was felt at 5th month. There was no history of gestational hypertension or gestational diabetes mellitus. Oral glucose tolerance test was done. Anomaly scan was done in the second trimester. She was continuing to take iron and folic acid supplements. One injection of tetanus toxide was given. Ultrasound scan done at the second trimester was found to have low-lying placenta, and it was advised to continue the pregnancy. Coming to third trimester history, there was no history of bleeding per PV, bloody show, or abdominal contractions. She continued to take iron and folic acid supplementations. Coming to menstrual history, coming to obstetric history, forgot to mention. She's a primary gravida with her last menstrual period on May 16, 2021, and her expected date of delivery was February 20, 2022. And the gestation age corresponds to 36 weeks plus 5 days. Coming to menstrual history, previous menstrual cycles were regular, 28 days with 28 days per cycle, lasting for 3 to 4 days with normal flow, and no history of OCP use, oral contraceptive pill use. Past history, there's no past history of blood transfusion, cardiovascular problems, tuberculosis, no past history of any surgeries. Coming to personal history, she had normal sleep and appetite, normal bowel and bladder habits, with increased frequency of urination for the past 2 weeks, and no history of any addictions. Coming to family history, there is no family history of diabetes, hypertension, multiple pregnancy, or any congenital anomalies in the family.
Can you again describe the initial complaint with which she has come to the hospital? She bleeding PV.
Bleeding per vagina.
What are the other for the past 2 hours?
Past 2.
Okay. Did you ask about the quantity? How much is the quantity roughly? Is it profuse? It is continuously coming or it is intermittent? You mentioned there are no. You said there are no clots. And what is the most important thing you should have asked whenever a patient says, for the past 2 hours, I have been having bleeding per vagina?
How many pads? Yes.
Pads, okay. That will give you rough an idea about the bleeding. But what is the most important question that should have been asked? Can you again describe what are all the things that you have said about that bleeding? Repeat whatever you have written initially. She came with complaints of bleeding per vagina for the past 2 hours.
No recent history of trauma, no
Trauma.
history of abdominal contractions, no history of leaking PV, no history of fever, no history of passing blood clots, and fetal movements.
Did you mention anything about pain there?
No history of abdominal pain.
Not abdominal pain.
Yes, sir. Pain.
That is the most important question that should
Painless.
have been asked. See, painless bleeding. That is the most catchy thing in the history that should have been asked, isn't it? So, what is the difference between a painful bleeding and a painless bleeding? What will you suspect if it is a painless bleeding? What will you suspect if it is a painful bleeding?
Painless bleeding can be seen in abruptions.
Abruption painless, is it? Placenta previa is painless, okay, because it is there in the os. It is on the way down. She is in the last trimester of her, so it is trying to get engaged, isn't it? 36 weeks. It is almost time for the head to get engaged. So if there is a placenta in front of the head, placenta previa, isn't it? That will produce a painless bleeding. That is a very, very important history you should never forget. Whereas if it is abruption, what will be the picture? Will there be what are all the types of abruption that can happen?
Can be concealed or revealed.
Concealed or revealed. So if it is concealed, will the patient have pain or not?
Patient will have pain, sir, but it will not have
it will go between the myometrium and the uterus will try to contract and it will be very painful. Concealed will be more painful, whereas revealed will be obviously bleeding. Okay. So that question you should never forget. That is a very important question that you should have asked. Okay. Right. And whether any symptoms of hypovolemia in this patient. When she says she last 2 hours she has been bleeding. First thing you should have asked is whether it is associated with any pain. whether it is vaginal or whether it's abdominal, whatever, or whenever there is a bleeding, is it associated with a crampy pain? That question first you should ask. Second thing is, to assess the quantity, you must see whether she has shown any evidence of hypovolemic shocks. What are the features of hypovolemic shock? Why it is difficult to identify a blood loss in a pregnant woman, that too when they are near term?
Already they will have hemodilution and they can allow up to 1.5 liters of blood loss. They can tolerate it.
That is the most important thing. Okay, so it is very, very difficult. Majority of the times, all the complications happen because of late diagnosis of hypovolemia. Okay, that is the most challenging thing in a pregnant woman, because nature has compensated them with additional plasma, additional RBCs, increase in blood volume, everything takes place to manage for the either a normal or an operative delivery. So up to 500 ml in a normal delivery as well as 1000 ml in an operative delivery, they can withstand without much of hemodynamic changes. Okay. So it is very difficult to find out what has exactly the blood loss. That is the most tricky thing. So by the time you try to identify their blood loss, they are much deeper into the stage 2 or stage 3 of hemorrhage. Okay. So how do you classify hemorrhage?
There are 4 classes of hemorrhage, sir.
Very good.
Based on either blood loss volume or percentage.
Okay.
So with percentage, it is less than 50%, 15% it is class 1. 15 to 30% is class 2.
Class 2.
30 to 40% is class 3. More than 40% is class 4.
Very good.
Based on volume, it is 750 ml less than is class 1. 750 to 1.5 liters is class 2. 1.5 to 2 liters is class 3. More than 2 liters is class 4, sir.
Very good. So that is how you, so this is purely that question also. So what will be, supposing she has gone into class 3 or class 4 hemorrhage, what would be the picture? Will she be telling you all the history happily like this?
She will be agitated or aggressive. Sometimes even she will go into unconscious state.
So when a patient comes with complaints of bleeding PV, you have to also say whether the history was completely given by the patient herself or by the attender. Okay, so that question, that explanation also has to be given there. So that will reveal whether the patient has become very severely hypovolemic or is in a state of shock, or whether she is still in a state of reasonable, acceptable blood loss only. Okay, so all these questions you should have asked in this to elicit a probable diagnosis. So what type of bleeding you will call this as? Antepartum or it is in the labor? How do you classify the obstetric hemorrhages?
Can be either antepartum, intrapartum or postpartum.
Intrapartum or postpartum. Very good. So under which category this will come? Will it come under antepartum or will it come under intrapartum or postpartum?
It will come under antepartum.
Antepartum. Why do you say it is antepartum?
It is it has crossed 20 weeks of gestation, sir, but the patient has not went into active labor.
She is not in active labor. Very good. That is the important point. So how do you find out whether she is in active labor or not? Maybe this is the heralding or the onset of labor. How do you know it is the bleeding which has started now? Yes. It is supposing the onset of labor. What other features you will have?
The patient will give history of show or any passage of mucus plug, and there will be active contractions can be seen.
She will start having regular uterine contractions. The uterine contraction pains will be there. Okay, so you must ask whether she is feeling the contractions and whether she is experiencing the contraction pain. Okay, so that is, if it is accompanied with that, maybe that was the, even on 36 weeks, some people can go into labor, isn't it? So with a, supposing it is a placenta previa and she has gone into labor, that could be the triggering factor for the entire bleeding itself. Okay, so that is another question that you should ask, whether she is feeling any quickening or contraction of the tightening of the abdominal kind of uterus, and whether there is any labor pain is there, features of labor pain is there, is also should also elicit that. Right. Now go ahead and complete your.
Coming to general examination,
Mm.
the patient is conscious, oriented to time, place, and person. She is afebrile. There is no pedal edema, icterus, anemia, cyanosis, clubbing, or lymphadenopathy. The neck veins are not engaged. Pulse was 96 per minute, regular in rhythm, normal volume, and all peripheral pulses are felt. BP is 108 by 72 mm of Hg in the right upper limb in supine position. Capillary leaf fill time was less than 2 seconds. Urine output, the patient was already catheterized on arrival, and around 150 ml of urine, which is of high colored, was drained. Coming to specific systems, respiratory system, respiratory rate was 16 per minute. Bilateral air entry was equal, and the normal vesicular breath sounds were heard on all quadrants, and no added sounds were heard. Coming to cardiovascular system, the heart rate was regular, and both S1 and S2 were heard. No added sounds and no murmurs were heard. Apex beat was heard on the fourth intercostal space, 1 centimeter lateral to the mid-clavicular line. Coming to abdominal system, on inspection, the abdomen was distended, umbilicus was everted, stria gravidarum was present. On palpation, the fundal height was at 36 weeks. There was vertex presentation. Abdomen was irritable, and on auscultation, fetal heart rate was around 150.
Abdomen irritable. What do you mean by that? Abdomen was irritable. What is that? I don't understand what you are trying to convey. What is the meaning of that? Abdomen is irritable. I can see a person getting irritated. How can the abdomen get irritated? Right. Okay. Go ahead. I don't understand what you are saying that. Okay.
Coming to central nervous system, the both motor, sensory, the deep tendon reflexes were normal. There was no signs of any focal neurological deficits. Coming to airway examination, mouth opening was more than 3 fingers breadth, and no loose tooths and dentures were present. Neck movements were adequate in all directions. The thyromental distance was more than 6.5 centimeters. Temporomandibular joint was mobile, and Mallampati grade score was 1. On examination of back and spine, there was no deformity of the spines seen, and there was no local signs of local infections. Coming to provisional diagnosis, it's a case of 22-year-old primigravida mother at 36 weeks of gestation with singleton fetus in vertex presentation. Coming with with antepartum hemorrhage for emergency cesarean section.
Okay. So she has been referred for cesarean to you, isn't it? That's how you have taken the history.
Yes.
So what is the diagnosis? What is the cause of this bleeding? That has not been mentioned at all. See, antepartum hemorrhage can be due to so many reasons. What exactly is the pathology which warrants an emergency cesarean section in this case? Have they done any investigation? How do you find out what exactly is the problem, and how did the physician decide that the patient requires an emergency cesarean section?
Yeah, we have to do ultrasound.
Ultrasound, okay. And she must have had an ultrasound in the antenatal period itself, isn't it? Right from the first trimester, they would have done repeated ultrasounds. Nowadays, they do ultrasound first to confirm at the 5th week, then at the 12th week, then at 20th week, anomaly scan like that. Okay. So what they could have found out earlier, if it is been.
The second trimester, they found that the mother had a low-lying placenta.
Low-lying placenta, very good. So it is not exactly a placenta previa, but it is a low-lying placenta. Okay. So normally, if you find a low-lying placenta in the first trimester itself, will you be worried?
No, sir.
Why?
As the pregnancy progresses, the placenta will rise up in the second trimester.
Go to the normal position. So you don't have to worry about. But if it consistently remains in the same position as the fetus is also growing, then you will have some worry in the back of the mind to see whether you have to take any steps to that. So antenatal checkup itself would have revealed. Was there any notes to say that there was a low-lying placenta in this female?
Except in the second trimester scan. In other scans, even in the third trimester, the placenta is risen up.
Is it low laying or it's a normal?
It became normal.
It has become normal. Okay. So what other, so if it is not a placental origin, what other could be the cause for this bleeding?
Can be any local trauma to the external genitalia can cause.
Hmm.
Even abnormal uh, variations of the placenta, like filamentous placenta, insertion of the placenta can cause. Or
If it is a filamentous or vasa previa, it could have also been revealed in the ultrasound, isn't it? And they have found the placenta is in normal position. Do you expect a filamentous or a vasa previa in this case?
no, sir, it
Not
cannot.
possible. As you say, it could be a trauma or even sexual intercourse at this stage, at the late pregnancy, sometimes causes a trivial bleeding in that. Okay, so the quantity of blood loss is very, very important. From what you have described, does she look to have an unmanageable bleeding?
No,
Her
sir.
condition. No. So her cardiovascular status does not really reveal that she is having a profuse or a very profound hemorrhage to warrant immediate cesarean section, isn't it?
Yes.
So why the physician is now insisting that she should have only 36 weeks, another 4 weeks to go for her to complete the term? Why they are insisting on emergency cesarean section at this time?
They have done a CTG, sir, and it has been non-reassuring. So it has a lot of bits. So they want to, since the baby is mature enough, they want to proceed with the.
Okay, they don't want to take any risk of waiting and then trying to go for a more severe bleeding and all these things. Okay, right. Now coming to the problem of bleeding in the antenatal period, how do you classify antepartum hemorrhage? I'm not asking about etiology. How can you classify antepartum hemorrhage, which is the hemorrhage occurring in the antenatal mother? Can it be classified according to the trimester? First trimester bleeding, second trimester bleeding, final trimester bleeding. Okay.
Yes.
So what are the etiologies or causes of bleeding in the first trimester?
First trimester, it can be either implantation bleeding,
Very good.
or it can be early abortion.
Miscarriage. Very good. Excellent. And then what is the most life-threatening bleeding, which may not be overt or seen outside, but it can happen intra-abdominally?
Ruptured ectopic.
Returned abortion.
Ruptured ectopic. Very good. Who said that? Ruptured ectopic is one of the important, but they will have trivial some spotting like thing only, but they may not have a profuse bleeding outside, but they come in a shock, isn't it? So if it is a ruptured ectopic, what are all the clinical features? That is also a massive emergency, obstetric emergency only, hemorrhage. So what will be the feature in a ruptured ectopic patient?
Patient will present to an emergency with poor, clumsy, pale skin.
Acute pain, first of all, it will be severely painful. You are always forgetting a pain. Being an anesthetist, your mind should always go for pain only. Okay? So the rupture of the fallopian tube produces a severe excruciating pain, which may mimic, supposing it happened on the right side. What are the other possible differential diagnosis for that?
Acute appendicitis.
Acute appendicitis, very good. Then
renal
colic. So all these possibilities are there. But what will? How do you differentiate between appendicitis or renal colic and ruptured ectopic?
Acute appendicitis will have a rebound tenderness.
How does it start? Appendicitis pain, how does it start?
It will start in the right iliac fossa first.
Straight away right iliac fossa? Actually, appendicitis pain starts around the umbilicus. Okay, circumumbilical pain migrating to the right iliac fossa, associated with nausea, vomiting, fever, leukocytosis, okay, and severe guarding and rigidity when you touch the right iliac fossa, and rebound tenderness on the opposite side. Okay, all these things are features of, and features of sepsis also may be there if it is there for 3-4 days neglected with almost a bursting appendix or an appendicular abscess. All these things will be the features of appendicitis, whereas the ectopic pregnancy occurs more acutely unless it has got sealed and covered with a momentum or something like that. Then it will be an excruciating pain with severe bleeding abdominally with features of shock. Okay. Whereas colicky pain of renal origin is intermittent and travels towards the lower urinary tract to the urethra and other areas. Okay. So you have to find the difference by the history as well as the presentation. So if it is a ruptured ectopic, what is the management? How do you diagnose the condition and what should be done for that? If the patient comes with a very thready pulse, BP 70/50, and
First
patient
initial,
is very disoriented or in shock, so how do you manage that patient?
so the first thing is patient has to be resuscitated, sir.
Very good.
So we have to simultaneously assess for blood loss and the need for fluid resuscitation should be started with either a 2 wide bore needle if possible, or a venous cut down if the venous access are very difficult to combine. And then warm fluid should be started.
Nowadays, do people still do cut down?
No, sir.
It was all yesteryears. When we were house agents, we were taught only to do cut down because central line and cannulas were not there. Okay, so don't mention that unless you want to show the examiner that you know that there was a technique called cut down. Okay, so nowadays all of you are all well trained in putting a central line. Okay, so any problem with peripheral line, you immediately you have an ultrasound, you can go for a central line cannulation and resuscitate the patient. Okay, right. Go ahead. So,
so initial
so
resuscitation.
what basic investigations you want in this case before you start the treatment?
Sir, blood has to be taken out for sent for hemoglobin, coagulation profile, and cross matching of blood.
Only hemoglobin?
Main is CBC with
hematocrit. Always don't forget hematocrit also in this sort of cases. Okay, any hemorrhage patient, not only the hemoglobin but hematocrit also is very, very important. Right. Then
coagulation profile and sample for blood cross matching for.
what do you mean by coagulation profile? What exact tests you want?
Prothrombin time and INRs along with APTT.
APTT. You don't want anything else?
Platelets.
Platelets. You should know the platelet count also and platelet value. Right. Okay. So just suddenly they may ask you, you can think that coagulation profile, if you say that word, everything will just leave you. But you have to know what are all the individual tests that are included in coagulation profile. Okay. Right. What is the difference between PTT and APTT? What is the expansion for PTT and what is the expansion for APTT?
APTT is activated
partial thromboplastin
time.
So what is the difference between partial thromboplastin time and activated partial thromboplastin time?
Activated is intrinsic pathway, sir.
PTT is extrinsic, is it? PTT value is longer. It takes longer time. That is why they have to get the values at a shorter time. So they activate it by adding kaolin so that the reaction will take place faster. Okay, so PTT was the original test, which took about 30 to 45 seconds is the duration of the test, is the value of the test. Whereas activated partial thromboplastin time, the value is between 6 to 12 seconds. Okay, so you get a result much faster. So that is why nowadays APTT is the standard test, not PTT. PTT was originally done. So prothrombin time, what does it indicate? Which segment of the coagulation cascade it decides?
Prothrombin time, it describes
Extrinsic pathway. Okay, extrinsic pathway you test by prothrombin time, whereas intrinsic pathway you can test by APTT and any other test. Common pathway, how do you test?
common pathway.
TT, what is TT? Table tennis.
Thrombin time.
Thrombin time. So remember these three. PT for extrinsic pathway, APTT for intrinsic pathway, TT or thrombin time for common final pathway. Okay. So that is how all the three tests are included in the coagulation profile. So all the things about coagulation can be the question full and full in cases of hemorrhage. Okay. So you must be thorough with your coagulation cascade knowledge. Okay. What are the two theories of coagulation cascade? The older one is the pathway, the coagulation extrinsic, intrinsic, and common pathway. What is the newer theory? Cell-based theory. Okay, cell-based theory is now slowly getting replacing the coagulation pathway theory. Okay, right. Okay, go ahead. So coagulation test you want to do. Then what else you want to do?
If the patient is conscious, I will start the patient on oxygen and put the patient in left lateral position.
Very good.
If possible, I will try to put in the head-on position or try to raise the legs. Then,
supposing patient's hemoglobin is 7 grams. Okay. Patient is, as I told you, is in shock. BP is 70, 50, pulse rate is 140, respiratory is 40, patient disoriented. So in this picture, how will you proceed to resuscitate this patient?
sir, in this case, since the patient is hemodynamically unstable, I will try to start transfusion protocols.
Massive transfusion protocol or simple transfusion protocol?
Initially, depending upon the requirements of blood units, if it is more than 6 units is required, I will try to go for massive. If it is less than that, go for transfusion protocol.
Okay, but now tell me what practically how will you deal with this patient? More than talking about theory, about transfusion protocol and all that, supposing you are in the emergency room and you see a patient like this with a pulse of 140, BP 70 by 50, patient disoriented, pale, and skin cold and clammy, and blood has been drawn and it shows a HB of 7 grams. So how would you proceed? You have already started 2 lines, as you have said, whiteboard lines.
Then I will try to give warm warm crystalloid fluids by the time blood products arrive. If there is availability of the particular specific type of blood, I will try to transfuse, or else O negative blood can be transfused.
How much of crystalloids or colloids you will try to give to resuscitate this patient? And what precaution you should take if you try to resuscitate the patient with crystalloid or colloid?
These patients can go into dilution, hemodilution. Sir.
Very good. So irrational or unplanned resuscitation with too much of crystalloids or colloids will worsen the condition of the patient. Why?
Here, the oxygen carrying capacity will be reduced.
Fantastic, very good. So you are diluting the blood more and more, isn't it? Already the hemoglobin is 7 grams. So if you keep on pumping more of crystalloids or colloids, you will not have any oxygen carrying capacity. You will be diluting that blood, and patient will develop tissue edema, acidosis. Lactate will go on increasing. Okay, so you will worsen the condition. Okay, so that is why you must try to. So what is the protocol that should be followed in an emergency like this with regard to the, would you give whole blood or will you give packed red blood cells? If so,
Packed
what is,
red blood cells. Packed red blood cells are.
what is 1:1:1 formula?
It's a fixed ratio transfusion, sir. For one ratio, one unit of PRBC, 1 unit of platelets, and 1 unit of fresh frozen plasma has to be transfused in the ratio of 1:1.
Where was this idea got from?
It is in the US military.
Military crash trial, very good. Trauma patients where they had a lot of bleeding. This was so all the treatment of obstetric hemorrhage was extrapolated only from the basic principles or concepts that were adopted in trauma survival or trauma resuscitation. Okay, so that is how the whole concept has been taken into this. Right. So that the first term, this could be the cause. What could be the cause in the second trimester and third trimester combined together? What are all the causes of bleeding that can happen? Antepartum stage.
In the second or third trimester, it can be a case of abruption placenta.
Placental problem, abruption,
Abruption can be there.
Okay.
Either previa or again trauma can be a cause. And if it is a previous cesarean sections or anything, that it can be uterine rupture can be.
Very good. Very good. So how to find out your uterine rupture? Supposing patient has gone on to early contractions, premature labor. So how will she present if she gets to a rupture? As you said, she had a previous cesarean section and she develops a rupture. What will be the clinical picture like?
With the rupture, the size of the uterus will come down, sir, and there will be maternal and fetal compromise. Maternal patient will, the mother can go into hemorrhagic shock or hemorrhagic shock, and it will go into hypolimy conditions. Whereas the fetal side, the fetus can go into fetal hypoxia, fetal distress, or fetal demise can occur.
You are still again not telling anything about pain at all.
Scar tenderness, sir. Scar tenderness, hematuria.
First patient will have pain and sudden relief of pain with a lot, as though that something has been relaxed in her body. Okay. So that will be the classic description. I was having excruciating pain. Suddenly the pain disappeared, but I started feeling dizzy and reeling. Okay. And if you palpate the abdomen, what will you feel? You can even feel the fetal parts. Yeah. இதெல்லாம் ஓஜியில் கரெக்டாக சொல்லி கொடுத்துருப்பாங்கல்ல, they would have taught you all these things. Okay. So rupture, which are all the sites where rupture can happen in an earlier operated case and a non-operated case?
Sir, in an earlier operated case, along the previous scar in
very good.
giveaway.
Non-operated case?
Non-operated case, in the lower junction of the lower with the upper segment will be thinned out.
Thinned out, okay. So prolonged labor, obstructed labor is one of the cause for rupture. Okay, in a previously non-operated patient, a prolonged obstructed labor is one of the reasons for the rupture of the uterus. Okay, so these are all the conditions which can produce antepartum hemorrhage. Intrapartum, what are all the causes of hemorrhage?
Intrapartum, use of instrumentations can lead, or vacuum suctions can lead to trauma. The second is early placental separations can lead to
bleeding. Okay. Any problem with the cervix which can result in bleeding? Inadequately dilated cervix and that the head is trying to come down can cause a cervical tear.
Yes.
By itself it can cause. Any perineal problem? Why do they do episiotomy, especially in the primary patients?
Episiotomy.
It is a controlled method of delivering the baby. Okay. Otherwise, they will go for perineal tear, which can be ragged with severe bleeding. Okay. So perineal tear and hematoma is one of the important causes of intrapartum bleeding. Okay. So cervical tear, perineal tear, placental abruption, placenta previa, all these things can result in intrapartum bleeding also. Now coming to the most common condition, postpartum hemorrhage. What are all the causes of postpartum after delivery of the fetus? What are all the causes of hemorrhage?
Usually they are classified as 4 T's.
Very good, excellent. 4 T's. What are all the 4 T's?
First is stone, sir. Second is tissue. Third is trauma. And fourth is thrombin, sir.
Thrombin, very good.
The tone is uterine atony, sir. Tissue, if there is retained products of conceptions.
Very good.
Third is trauma, any genital tract trauma or cervical trauma.
Very good.
Fourth is thrombin, sir. Either it is an inherited or acquired coagulopathy.
Coagulopathy, very good. So what are the causes of the atony of the uterus resulting in postpartum hemorrhage?
It can be either obstetric cause, a maternal cause, or a fetal cause.
Very good. What are all they?
Obstetric cause is multigravida.
Multipriority, very good.
Then
prolonged labor.
Prolonged labor, previous history of any PPH, uterine atony. And
multiple fetuses.
Multiple gestations. And even gestational hypertension can cause, preeclampsia can cause.
Very good. Right. So if it is diagnosed as uterine atony as the cause of PPH, what are all the steps in the treatment or management of that condition?
Sorry, initially we have to increase the dose of oxytocic agents possible. Active management of blood level should be done usually. But if it is failed, then we have to go for either uterine massage from there. Uterine massage and
can you classify that into pharmacological and interventional methods?
Yes, pharmacological and interventional.
Always first thing is they all try to use the uterotonics, isn't it, to contract the uterus. What are all the uterotonics that can be administered?
So, for most common is oxytocin, sir.
Oxytocin. Will you give it as a bolus or will you give it as an infusion?
Sir, it is advised to give as an infusion more as, than a bolus. But if bolus has to be given, 2 to 3 units of international units can be directly given as IV. But
what is the disadvantages of oxytocin in large doses?
Sir, it will lead to tachycardia and hypotension. And
water intoxication.
Okay, right. What is the next drug of choice? Supposing oxytocin is not, ergometrin is a very powerful uterotonic.
Muscle contract.
But what are all the disadvantages of the drug? Is it being used nowadays?
Not frequently, sir. But
recommended.
It is not recommended. But
why it is not the recommended drug nowadays? Previously, when we were PGs and house surgeons or even as anesthesia, all the physicians ask us to give ergometrin 30 milligram IV and 1 ampule in the directly intramyometrium. That was the practice in those days. And the uterus will immediately shrink into a cricket ball consistency, become hard and tight. But what will the patient complain of? Have you ever administered ergometrin and
nausea and vomiting, very common.
Headache, severe headache because it causes hypertension. Patient will immediately complain of severe headache. Those days it was very common. So that is the reason why, especially if the patient has a pre-eclampsia or the chances of eclampsia are there, it is a really
Gestational hypertensive
depressed
patient.
state. Yes. So it is not
Contrary.
commonly used now. What is the other third alternate for that?
Prostaglandin analogs can be used.
Prostaglandin analog, carboprast. Isn't it?
F alpha.
Okay.
It is
So
also will cause diarrhea. And you have to
these are
look
all.
for
So any anesthetic techniques given in the during delivery, will it cause the atony of the uterus? Supposing the patient has been given GA.
Inhalation.
Inhalation agents.
anesthetics. All right.
So all the inhalation agents can be the causative factor for uterine atony also. So better to keep them. That is why you are supposed to reduce to less than 1 MAC value only you are supposed to use for maintenance of anesthesia if you are administering GA for these patients. Okay, right. So that is the pharmacological method. What are the interventional or non-pharmacological methods to control the or
Either it can be surgical or interventional, sir. Surgical, you can go for either a compressive surgery, uterus compression surgery like breathing suture or row sutures, cho sutures. Or you can give tamponade like effect, either with a balloon tamponade like Bakri balloon or a Sangas Blackmore tubes like that, sir. Or the interventional, we can selectively thrombolize or embolize the vessels that supply the artery.
Very good.
Most commonly anterior trunk of that internal iliac artery. Even though some branches can give selective angiolysis can. At the end stage, we can go for peripartum hysterectomy.
Hysterectomy, very good. So these are all the various stepwise management of uncontrollable bleeding because of atony of the uterus. Okay, right. So supposing it is a retained placenta, and that is why it's bleeding, and the patient had a normal labor, she has delivered the baby, but the placenta is not coming out, and there is a bleeding, and the physician calls you for help. How will you give anesthesia for removal of the retained placenta?
Sir, if the patient is hemodynamically stable, we can go for with monitor anesthesia and IV sedation.
Sedation with what?
With induction agents like
Thiopentone, propofol, etomidate.
if it is cardiacally, hemodynamically stable, we can go for propofol and thiopentone, sir. If the patient is unstable, we can go for ketamine, and secondarily we can go for etomidate. Ketamine will have advantage of post-op pain.
So it is a very short procedure, but it is a slightly painful and discomforting procedure because the surgeon has to put her hand inside the uterus and separate the placenta and pull it out. So it's a momentary discomfort and pain. So a sub-anesthetic dose of ketamine is more than sufficient. Okay, instead of going in for thiopentone, propofol, and all these things, a sub-anesthetic dose of 0.1 to 0.2 milligram per kg body weight of ketamine is ideal for managing this situation, which is a very short procedure. Okay, so that is about the management of retained placenta. But if it is a thrombin, as you said, a coagulation problem, how would you proceed?
Most probably.
What is the in thing that you will do nowadays?
Point of care.
Very good. Point of care testing with thromboelastography. Okay, that is the most important thing. What do you know about thromboelastography?
Thromboelastography, here we'll have a we have a pin and a cuvette, sir. In a cuvette, we will collect 0.2 ml of the blood sample from the patient, and that cuvette will be rotating at a constant speed, and a pin will be kept on the tip of that sample. As the blood clots, that tip of that pin will be pulled away, which will draw the graph over the.
You know the name of the person who found out this machine? Helmut Hartrecht, a German scientist. Okay, Helmut Hartrecht was the person. அவர் கண்டுபிடிச்சிருந்தா விட்ட நீங்க புதுசா ஏதோ மாடிஃபிகேஷன்லாம் சொல்றீங்க அதுக்கு. You are telling that the pin will go and draw and all that. It's not like that. See, the cup rotates and the clot forms. So there is a tension built up in the pin that is inserted into that cup. Okay, that is transmitted via transducer and electrical signals are created, and that makes the graph. Not the pin will not directly நம்ம வைட்டலோகிராஃப் மாதிரி இல்லை. This is not like a வைட்டலோகிராஃப் pointing on the drum and then trying to measure all the values. This is a transmitted signal which is going to give you. So what are the basic information you will get in a thromboelastograph?
First is the clot formation time.
What is that called?
R time or reaction.
R time.
Then there will be case
K time or
then the angle formed between this R reaction time and K line will be the alpha angle. Sir.
Very good.
Then there will be the
maximum
amplitude, sir, followed by lysis time of 30 and 60.
So it measures both coagulation activity and fibrinolysis activity, not thrombolysis, fibrinolysis activity. Okay, so that is why it is very, very important. And nowadays, being originally, where was it used? This thromboelastography, in which particular surgery or condition it was primarily introduced into?
Transplants.
Liver transplants, especially. Okay, then it is now extrapolated to all cardiac surgeries and obstetric hemorrhages. So wherever you require, what is the advantage of using this TEG or thromboelastography? This is one of the questions that can come in your theory paper also. That is why I am taking a little time to explain all these things.
Depending upon the variation in each part of the graph, particular blood products can be given.
Excellent.
And this can avoid excessive
unnecessary overloading with bulky whole blood. Okay, so instead of dumping the patient with whole blood without knowing what is exactly the deficiency, we can now selectively replace whatever factor or the component that is missing so that we don't unnecessarily load the patient. Okay, so what are all the four primary things that you will deal with if you are going to use TEG? What components of blood you will be commonly using?
Fresh frozen plasma, sir.
Very good. Then
platelets.
Platelets, very good.
Antifibrinolytics.
Huh?
Antifibrinolytics can be.
Antifibrinolytics. What do you mean by that? Any example? Tranexamic acid.
Tranexamic acid.
That is not a blood component. That is a drug.
That's not a per se.
Now that you have committed, what is tranexamic acid? Biochemically?
EAC, sir.
You are using it day in and day out nowadays in all your ortho cases and other cases, isn't it?
Epsilon aminocaproic acid.
Is it tranexamic acid? Epsilon aminocaproic acid. Who is that? My God. That is IACA. That is a separate drug, Tambi. That is not the same thing as tranexamic acid. Tranexamic acid is a synthetic analog of essential amino acid L-arginine. Okay, I mean lysine, not L-arginine, lysine. So it is a synthetic analog of lysine is tranexamic acid. Okay, right. So that is not a blood component. That is a drug. So the blood components are fresh frozen plasma, platelet, cryoprecipitate, fibrinogen concentrate, prothrombin concentrate. These are the 5 things that are now available. These are called the blood components. Okay, so we can use that So ideally for correcting the deficiencies using the thromboelastography. What is the difference between thromboelastography and ROTEM, rotational thromboelastometry?
Main difference is here the sample container will rotate in TEG, whereas the rotational
pin will rotate in the
rotate
that is why it is called rotational. The pin rotates there. Okay, but more or less both the things are little same only. Okay, and the volume of blood required is not 0.2 ml, but it is 0.36 ml. Okay, 0.36 ml, 0.3 ml roughly. That is the very small amount of blood is only needed. Should it be whole blood or should it be the anticoagulated blood?
Whole blood.
It should be whole blood. You should not add any citrate or anything to that. Okay. So that is, these are all some of the questions that you have to be ready to answer that. So TEG is an important thing, which is now very useful in management of this hemorrhages that happen in the postpartum period. Okay. Right. Now, if you want to give a massive transfusion for a heavily bleeding patient, what are all the things that you will do? What is the algorithm that you should follow? What are all the equipments that you need to replace that blood loss?
Algorithm to follow is we have to activate massive transfusion protocols.
Very good.
So
What do you mean by massive transfusion protocol, MTP?
When we require more than 4 to 6 units of transfusion within 4 hours, it is usually a massive transfusion protocol is activated. It is to enable rapid.
You have gone through your question papers. Repeatedly, this question has been asked: massive transfusion protocol or complications of massive transfusion. What do you mean by massive transfusion? This is a repeatedly asked question. Okay, so you should have a clear concept about that. So, what is the more? When you say massive transfusion protocol, it is a multidisciplinary work, multidisciplinary team approach, isn't it? So who are all the people involved in that? Is it only the anesthetist or only the physician, or who are all the other people involved in that?
The blood bank staff and
transfusion medicine people, very good. The physician, the anesthetist, the nurses, the porters, everybody is involved in that. Okay, so it's a multidisciplinary team approach. So once you decide that a patient requires a massive transfusion, you must give a alert or inform everybody. Okay, that is the first and foremost thing in the protocol. You must alert everybody. You must tell the blood bank that here is a patient who is not contracting after delivery. She is losing a hell of a lot of blood. So we are going in for massive transfusion protocol. So the blood bank will immediately search for the group and find out whether they have adequate stocks or they have to alert or get from some other place. So first they send it in batches or shipment, first shipment, second shipment, like that. How much of blood should come in the first shipment? As soon as you announce that the patient is going in for 14, 4 to 6 units of the compatible blood. Supposing if compatible blood is not available, what will they do?
You can go for a common donor, O negative.
O negative blood. So there is in some hospital, there is a thing called transfusion pack. What does that contain? Massive transfusion pack is there. What should be that pack should contain?
It should contain packed red blood cells.
So it will contain 4 units of O negative blood, 4 units of platelet, and 4 units of fresh frozen plasma. Okay, this is called massive transfusion emergency pack. Okay, And nowadays they include fibrinogen also into that. Okay? So all these things are included in that. So yeah, the speed with which we replace the blood loss is very, very important. Okay, so that we can. So our aim is to resuscitate the patient from going in for irreversible hemorrhagic shock. What will happen if the patient goes into irreversible shock?
Uh,
Or in other words, what are all the reasons for death in a massive hemorrhage?
End organ failure, sir. Cardiac arrest.
End organ failure arrest is the final end for all that. But what is the pathology that will happen?
Disseminate.
First thing is the patient will go in for irreversible shock. So patient goes in because of lack of oxygen carrying capacity. There is a reduced oxygen delivery to the tissues. So all the organs go in for anaerobic metabolism. Lactate accumulates, metabolic acidosis sets in, and all the enzyme activity gets depressed. Myocardial depression happens. Catecholamines don't work. That is how the whole pathology happens. And in addition to that, what will happen? There will be consumptive coagulopathy. Nature will try to arrest the bleeding by utilizing all the coagulation factors that are available with that. And that will lead to further more bleeding. Okay, so the possibility of DIC, disseminated intravascular coagulation, is also there. Okay, so if supposing patient has gone in for DIC, how do you know that? What are the clinical features of DIC?
The patient will be both bleeding as well as clotting at the same time, sir. So there will be signs of hemorrhage from gums, and the ecchymosis will be there, and effusions will be there. At the
Which
same
is the
time,
simplest clinical evidence of DIC, ma'am? Easiest method of identifying DIC. All the puncture sites will start oozing, which you have tried about 1 hour, 2 hours prior. Okay, vein கிடைக்கலன்னு ஒரு 4-5 இடத்துல you would have tried puncturing and trying to get a vein. All that sites will start oozing, which were punctured 1 hour, 2 hours, 3 hours earlier. Okay, that is the classical method or presentation of DIC. Puncture sites which had been completely sealed will start oozing. Okay, that happens. That is the most easiest method of identifying DIC. So if a patient is diagnosed to have gone in for DIC, what is the best method of treating that? What ultimately is lacking in DIC? Initially, there has been thrombi formation. Which coagulation factor will be utilized for making this thrombus? Fibrinogen. So the ultimate treatment for DIC is
fibrogen concentrate.
Fibrinogen concentrate replacement. Okay, so that is the only way to salvage the patient who has gone in for DIC. Okay, so these are all the points that you have to remember with regard to the massive transfusion and all that. Now coming to the final treatment of, you said about cesarean hysterectomy, and all the conservative methods and the interventional methods fail. If you want to save the patient's life, you have to remove the entire uterus and stop the bleeding, because it is not contracting anymore on the postpartum period. So what are the challenges you will face in the management of a cesarean hysterectomy, which is done as an emergency? And what is your anesthesia of choice? Supposing a patient who has delivered in the labor ward fails to contract, gone in for a severe postpartum hemorrhage, and the physician decides that they have tried all the bimanual compression sutures and all those things have been tried, and so they finally decide that emergency hysterectomy is to be done. So in that case, they call you. Patient has delivered normally. Okay, so you are called in for emergency hysterectomy in a patient who has undergone delivery. So what are all the, how will you, what anesthesia you prefer to give for this patient?
Sir, first I would go and assess for blood loss, sir,
Very
and
good.
assess the degree of
Okay.
shock.
Mm.
And then if resuscitation is needed, first resuscitation should be started.
Okay.
Once, if possible, if patient is resuscitated and hemodynamically stable,
Mm.
and there is no signs of any coagulopathy,
Mm.
I will go for regional anesthesia technique with central neuroaxial block of spinal subarachnoid block, sir.
Mm.
If the patient is hemodynamically unstable
Mm.
and immediate hysterectomy is to be done,
Mm.
and or if signs of coagulopathy with the low platelets are present, I will go for general anesthesia immediately with rapid sequence intubations.
Mm.
And depending upon if the patient is enough resuscitated and planned for rapid sequence intubation, instead of propofol, ketamine can be given.
Very good. Mm.
Or ethambutol can also be given in case of cardiovascular instability.
Stability. Okay. Mm.
And,
What is hybrid procedure? Or hybrid operating theaters? Have you heard of that? What do they do in that?
like double setups.
Hmm?
Like double setup or
Double?
like double setup you are asking.
Double setup. That's called hybrid. What do they
Both.
do in hybrid? Hybrid cardiac theaters are there, hybrid OEG theaters are there. Nowadays, they combine embolization before attempting for hysterectomy. Okay, to reduce the intraoperative blood loss, they have facilities for endovascular or interventional coiling or blocking the vessels. Okay, so they do the embolization of the uterine arteries followed by hysterectomy. Okay, so if both can be done in the same theater, that is called the hybrid operating theater. Okay, where you can do first the radiological intervention followed by the surgical procedure in the same theater. Okay, so this is available for coronary, this is available for obstetric. So all these things are now, they are all large operating, very large areas where you can have the radiology machines as well as the operating table will be there. So that is what is called the hybrid procedure.
Hybrid.
So if it is hybrid procedure, they have tried both combined spinal epidural, they have done continuous spinal, they have done GA, all these things. But majority of the anesthetists prefer to give GA because the time is not constant. The operative time may vary between the sessions as well as with the time, the patient's condition. So instead of converting from a regional technique to general anesthesia, some people prefer to straight away go for GA so that you can have a good ventilation, maintain oxygenation of the patient, and also patient discomfort is much lesser. If they have to, supposing the surgery goes on for 4.5 5 hours, then the lying supine in a conscious state is very difficult for the patient. So to avoid that, they try to go for general anesthesia straight away. Okay, so these are all the points that you would like to know. What is the role of recombinant factor 7A?
Recombinant factor 7A, the NOVA 7, sir. They are now usually first started in trauma induced shocks, resuscitation.
Very
Now
good.
their studies have been done in obstetric postpartum hemorrhage and hemorrhages also, sir. The only problem is it's very expensive.
Excellent.
So
and the results are not guaranteed.
Not guaranteed, so controversial.
What is the mechanism of action of this recombinant factor 7?
This will cause that sudden thrombin burst, sir. So this will block all the open vessels, open bleeding vessels.
Because thrombin burst, recombinant factor 7A is the, so what is the role of factor 7 in our coagulation cascade? Is it an extrinsic factor, extrinsic pathway or intrinsic pathway?
intrinsic pathways?
Factor 7. Tissue factor and factor 7. They are the extrinsic pathways starting, isn't it? Tissue factor activates factor 7 to factor 7A. Factor 7A will in turn activate factor 10 to 10A. Okay. So this recombinant factor 7A, we are mimicking that extrinsic pathway component. Okay. But it also activates directly the factor 10A. Okay. So it has got both the actions, and as you said, it's quite expensive and the results have not been conclusively proved unless you find a deficiency of factor 7 in patients, then which will be shown by prolonged PT. Then you can try recombinant factor 7A. Otherwise, it is not useful. What is the role of cell salvager?
Cell salvagers, it can also be done, sir. But intraoperative cell salvage technique have been practiced, but the results are not yet conclusive, sir. Here also we have to first remove that amniotic fluid, so that chance of amniotic fluid embolism should be.
So contamination with amniotic fluid is the most important problem that was there. So how did they overcome that? Now they are using or recommending cell salvager, especially in cases of placenta previa, where there is a heavy bleeding occurring. They collect that blood and reuse it. But what are all the adaptations they make to utilize that blood?
So first they will suction out as much as possible amniotic fluid, sir.
Dual suction. It is not a single suction. There is a dual suction to separately remove the amniotic fluid and collect it elsewhere and remove the blood which is coming later on. Okay, so the dual suction method is number one. Number two, when they wash it with saline, they found that majority of the amniotic components have been removed. So you can safely reuse that. Which particular type of patient it will be useful?
Jehovah's Witness.
Jehovah's Witness, very good. So they have Jehovah's Witness who refuse blood from allogenic people. Their own blood sometimes they accept. And the recombinant factor 7A also is sometimes useful in Jehovah's Witness patients. Okay, so in those patients you can use. So I asked about the question of what equipment you require for rapid transfusion of massive rapid infuser. What are the components of this rapid infuser system?
Microprocessor.
What is level one rapid infuser, which was originally used again for liver surgeries, especially transplant surgeries of the liver. Now it is being used in all massive transfusion protocols. What are the components and how does it help?
Pump will push the
blood. What is the amount of blood that you can pump into the body per minute maximum?
Per minute 500 250 to 500 ml.
That is very low. Can go as high as 1400 ml per minute. Okay. And it is all warmed also. There is a heating element which can improve. So warmed fast flow of blood can be, or even your other products or the fluids can be given at a very rapid rate using this rapid infuser, which warms all the fluids that you give. Okay, so that is one of the important equipment that you require for resuscitation in cases of massive bleeding. Okay, right. So I think that will almost complete whatever discussion we have to make. And any